I want to thank Maren for his kind words, and I want to thank Sages for inviting me. As a matter of fact, I did perform the first robotic procedure in 1997, so that makes me more of the grandfather of robotics than a father. I must also give credit to Carlos Vaz, who is a robotic surgeon in Lisbon, Portugal, for helping me with this talk. When we had done the first laparoscopic cholecystectomy by robot back in 1997, a few years later, the company came to my hospital, which was a hospital in Dendermonde, and they offered the robot for free. And actually, the administration said, "Well, that's not interesting. We don't want this robot." So that's when I first understood that economics in robotic surgery is not that simple. Here are my disclosures. Now, when we look at the literature, unfortunately, robotic surgery doesn't have that good a press. And when we look at the more recent papers here in rectal cancer treatment by robotic surgery, we see that the outcomes comparing the rectal cancer surgery by robot, by laparoscopy or open surgery, actually was not too much in favor of the robotic surgery. Robotic surgery was associated with higher cost and did not seem to offer any advantage over laparoscopic surgery in terms of mortality and complications. And when we look at the literature, this is all the literature, but we see that the consensus usually is that robotic surgery doesn't really make much sense economically, at least not in the treatment of rectal cancer. And this is a recent study that was published in JAMA, where we see that robotic-assisted surgery did not actually offer any benefit compared to laparoscopic surgery in terms of the incidence of conversion to open laparotomy. Now, the problem is that it all depends on the method of the study. It all depends on the parameters. It depends on the benchmarks. And when we talk about conversion, that's just one aspect. But there are many more aspects. That's what I will try to talk about in this short presentation. When we look in other domains than rectal surgery, we see here for laparoscopic hysterectomy that there is a clear benefit of robotics in terms of economic advantage for benign disease compared to laparoscopic and compared to open hysterectomy. In other fields, however, we see that, and this is a study coming from Scandinavia, we see that this is a randomized controlled trial, and we see that the robotic surgery for endometrial cancer, again, makes surgery much more expensive without really showing any clinical benefit. So again, here, we could really question the usefulness of the robotic surgery. But when we look at costs, I think we have to go beyond the obvious. The obvious is obviously the OR time, the blood loss, the length of stay, conversion rate, but there are lots of other factors that are worth focusing in. And those other factors are the dynamics of costs. What are the perspectives of the costs? Anwar just mentioned the difference across the world in different countries. So it very much depends on the types of reimbursement. It depends on how you can negotiate with the providers, how you can negotiate a price of reimbursement. The break-even analysis is, of course, a consequence of all that. Human resources differ so much and vary so much across the world, the same as overhead. And I want just to make a comparison with gastroscopy. In my country, which is Belgium, a gastroscopy costs €200, whereas a gastroscopy here in the US costs something like $3,000. So there's really a tremendous difference across the world in terms of costs, direct and indirect. But this implies also a risk analysis. And does it still make sense to work fee for service? And in many countries, that no longer is the case. And in Belgium, there's a big question as to stop with the fee-for-service system. What is the global budget that the reimbursement organisms can offer for robotic surgery? What are the sunk costs? How do we amortize the cost over how many years? And finally, do we have the tools to perform a true and valid cost effectiveness analysis? There's a paper, it's a little bit of a busy slide, but that was published a few years ago coming from Korea, but I want you to focus on the little blue square, and you see that the total hospital charge and payment were higher in the early period. And that's why I'm saying this is really a dynamic study, because early on you see that there's a tremendous difference between the laparoscopic and the robotic procedure. But you see that with time, the lines come closer together and the differences become less obvious. The conclusion of that study coming from Korea was that still there was a difference in price, but the difference became smaller between the laparoscopic and the robotic surgery. And the cost effectiveness of the robotic rectal cancer was to be estimated not only by direct costs, but also by outcomes. And actually we see that when we look at the evolution or the progression of rectal cancer between the robotic surgery patients and the laparoscopic surgery patients, we see that there's a trend. It's not statistically significant, but there is a trend in favor of the robotic surgery in terms of overall survival, cancer-specific survival, and disease-free survival. You see this is a marked trend, but there's no statistic significance, unfortunately. Now, when we talk about cost, and we knew that from the laparoscopy era, we know that there's a tremendous difference across the countries, okay, but also within one country. And this is a study from different centers in Portugal. And you see that the impact, for instance, on the use of reusable instruments and trocars, or the disposable instruments and trocars for laparoscopy, caused a tremendous difference, again, between the different hospitals in terms of total costs. And we know that with the robotic, we know that what's actually the most important source of revenue for the company that manufactures the robots is this here, is the instrumentation. And you see that out of 2.27 billion annual revenue, we have that 46% or 45%, I can't really read, is derived from the instrumentation. In other words, projections concerning costs of robotic surgery must incorporate the anticipated impact of additional equipment manufacturers, other companies that would emerge and that would reduce the cost of those robotic instruments. That was published 2 years ago in Surgical Endoscopy. Now, so because of that monopoly from Intuitive, it's clear that the instrumentation is probably too expensive, and that is why in bariatric surgery there's a recent paper that was published with Phil Schauer and others and Al Saber, and we see that the robotic-assisted procedures had the highest impact on costs, and we see that there's a marked increase in costs of robotic surgery in terms of bariatric procedures compared to the simple laparoscopic procedures, if you will. But that study, again, was flawed because we see that there was no incorporation of the incidence of postoperative complications. And that was because it was those data were derived from the NIS database, and those data did not incorporate the complications. And we all know, I'm a bariatric surgeon, so I can tell you that we all know, and we just heard it in the first session today, that prevention of complications is the key factor to shorten hospital stay and costs. And actually, we know that when we look at the length of stay, which is linked to the complication rate, we see that when we look at the mean cost, it increases tremendously with time with the length of stay. And this is for the Roux-en-Y gastric bypass in blue, but this is also true for the sleeve gastrectomy. So we have all interest in keeping our patient as short as possible in the hospital, and that we can only do by avoiding complications. So the question is really, do we avoid complications with robotic surgery? And this is a study coming from Switzerland, and we see that robotic Roux-en-Y gastric bypass can be cost-effective precisely because of that, because of the savings associated with avoiding anastomotic complications, but also by avoiding the use of staples. In other words, by performing manual anastomosis. We all know Kelvin Higa's technique, and I know that very few surgeons are capable of doing a decent laparoscopic manual anastomosis, which is something that with the robot has become much more easy. And so therefore, we can avoid staples, we can reduce the cost, and we can at the same time avoid anastomotic complications, which is really the aim of the whole ball game. This is that study from Switzerland, and we see that the comparison between laparoscopy and robotic in terms of leaks, we see that the incidence dropped from 4% to 0% in this, and the incidence of reoperations dropped from 4% to 0.7%, which was both significant. So the use of robot, at least in this study from Switzerland, seems to make a lot of sense. Now, again, I'm a bariatric surgeon, so I wanted to look into the use of robots in sleeve gastrectomy besides Roux-en-Y gastric bypass. And why would a robot be used for a sleeve gastrectomy? Because of this, because many people want to oversew the staple line. And obviously, with the robot, this is something that's much simpler and actually much faster. This is a study coming from Spain from my friend Villalonga, who found, and that was a randomized study, who found that between robotic sleeve gastrectomy and laparoscopic sleeve gastrectomy, there was no significant difference in leak rate. And in terms of operative time, we see that there was a slight increase in operative time, which reached just statistical significance. When we look at the literature, this is a review that was published in Annals of Surgical Innovation and Research in 2015. What's striking is that when we use a robot, there's different types of procedures. And we see here that there's an incredible variation in surgical time. And obviously, with surgical time, we mean that we understand that that will increase the cost. So when you see that Villalonga and others did about 1 hour for a sleeve gastrectomy, some others did 2.5 hours or 1.5 hours. So it is really a significant difference. Now, the robotic sleeve gastrectomy in this study that was published in 2013, we see that despite the fact that the surgical time was indeed longer in the robotic approach, the hospital length of stay was lower. And remember that graph that I showed you earlier, the cost depends so tremendously much on the length of stay of the patient. So here, even for a sleeve gastrectomy, we see that because the length of stay is shorter, it probably makes sense to at least contemplate the use of the robot for a sleeve gastrectomy. When we look at the direct cost of a Roux-en-Y gastric bypass, however, in obese adults between 18 and 65 years, this is the Bailey study of 2014, we see that this is meta-analysis coming from 1,374 potentially relevant studies. Only 10 were really relevant sufficiently. So we talk about 2,557 patients. And we see that overall there was a longer operative time for the robot. We see that in terms of complications, there was no significant difference between the robotic and the laparoscopic Roux-en-Y gastric bypass. And what we do see is that in direct costs, but again, I gave you the limitations of that aspect, we see that the robotic Roux-en-Y gastric bypass in those days, which is 4 years ago, we see that the cost estimated was $15,000 some US dollars for the robotic and $12,000 for the laparoscopic Roux-en-Y gastric bypass. And so the limiting factor in that study was the use of staples again. So again, if you can reduce the cost of staples, you can probably narrow that difference between the robotic and laparoscopic Roux-en-Y gastric bypass. What are the other factors that we have to look at in terms of robotic surgery versus laparoscopic surgery? And I think in real cost evaluation, we have to look at the 4 components, the 4 stakeholders in the real cost evaluation. First of all, obviously, the hospital. We heard this morning in the previous session that was very interesting that we have to improve our OR utilization, and that by increasing the utilization from 70 to 80%, we gain the equivalent of one OR, 1,400 to 1,500 patients, and more importantly, between 1 and 1.3 million euros of gross margin, which is about times 1.2 in dollars. And we see that to increase the cost efficacy of the robotic surgery, what we want to do is we want to indeed increase the number of procedures. And I don't know if you can read this well, but you will see that with the annual caseload increasing between 50 to 100 to 400, we come from a value from a net program cost of $3,000 to less than, to minus $1,000. This is a Canadian study, by the way, Maren. Okay. So I want to talk for 2 minutes about the robotic single-site versus laparoscopic cholecystectomy for a simple reason, because this is a study that was, I think, very well conceived. And here we see, and this was totally unexpected, that in a hospital, and that's why I'm saying this is a dynamic study, cost is a dynamic study, when we have a hospital that has an acquired infrastructure for robotic surgery, with a team that's dedicated to it, with a well-trained team that doesn't change every day, we see that the costs for the robotic procedure, which is the single-port cholecystectomy, those costs were lower than laparoscopic cholecystectomy. And that was mainly driven by cutting down on the supplies and by reducing the OR time. And when we look at the, you could say that, of course, the robotics were easier cases, but look at this, you see that the robotic cases were in majority emergent, whereas the laparoscopic were elective. And we see that that's why the outpatient procedures were more in the laparoscopic group than in the robotic group. So it was not a question of, and it was statistically significant, it was not a question of choosing the easier patients for the robotic procedures. And when we look at, indeed, at what was a significant difference in cost, it is supplies, and that was significant and brought a total reduction of cost that was highly significant between the two groups. What are supplies? Supplies include all non-anesthesia and non-respiratory disposable or semi-disposable material, as dispensed and billed by our OR central distribution. So that's really everything going from a Band-Aid to the catheter, etc. Again, we heard about that earlier today in the first session, which again, extremely interesting. But we see that the multi-use disposable instrument in robotic cases are calculated per case instrument price divided by the number of uses. So we can increase the number of cases that will, of course, reduce the cost. Another aspect is the patient, and I have to zip through that. Very important thing is the quality. I think the quality of our surgery as experienced by the patient. Quality depends on the appropriateness multiplied by the outcomes plus the services. So that means that when we perform an appropriate surgery, we have a factor 1 here, which means that the quality is directly proportional with the sum of the outcome and the services divided by the waste. And that allows us, for the patient, again for an individual patient, to evaluate the true value. And you see that the cost of delivering the outcomes is here, the divider with the health outcomes that matter to the patients. The important thing is how the patients evaluate their outcomes. I'll zip through this, but in this study that was published in Hepatobiliary Surgery and Nutrition, we see that the value-based assessment of robotic surgery for pancreas and liver here highly focuses on the quality of life, survival, and return to independent function. And this is extremely important. This is the formula that was found in that paper. It is extremely important because the patients more and more report their outcomes, and that is something that is being used more and more in the registries. We want to know how the patient report, how they experience their outcomes, not only the bare data, but also the way the patient experiences all that. And this, do not underestimate that, because now we're in the internet era. Patients communicate with each other, And that's why that was already found in 2006, there's a true internet marketing of bariatric surgery. And patients do walk to our office and they say, listen, doctor, I know I need bariatric surgery, but I want it robotic. Why is that? Because we just talked about it in our internet group. And that's what explains the increase. This is an Indian study of different procedures, hysterectomy, prostatectomy, and other procedures with time. This is more an internet-based thing. I'll zip through the surgeon just to tell you that we all know that conventional laparoscopy, because of the reduced number of degrees of freedom and the awkward positioning, induces fatigue in the surgeon. And I'm well placed to know that because that really killed my back. And thanks to the laparoscopic, the robotic surgery, we have better ergonomics, which reduces the damage to the patient, to the surgeon's spine. And then finally, what we want to know is we want to also study the education and robotics. Robotics does help in education. We could teach our procedures much better because, of course, of the distance between a patient and the visual access, but also because it's very simple for a student to look over the surgeon's shoulder to learn a procedure. However, we have to take care, of course, that the fact that we implement robotic surgery does not reduce the caseload in terms of laparoscopic surgery. So the take-home messages are, I think we have, the cost analysis so far are not reflecting the actual cost. It's much more complicated than that. It's a dynamic thing. The evaluation of the cost is something that varies every day. Standard measurement of cost and outcomes may vary across countries, and Dr. Barry already mentioned that. Risk sharing should be part of the cost assessment. Need for multi-center prospective randomized studies, of course, including patient satisfaction rate is becoming increasingly important because of the role of internet. Educational benefits were briefly discussed, and of course the competition between the robot providers will reduce the price of instrumentation. And remember, that was the most significant cause of a high dollar load for the procedures. I thank you.